Conference will now be recorded.
Sorry about that. My bad.
Actually, you can just leave it on, Rick. We can start. It's 8:08. We got a good group in here. So, all right. I told everybody this meeting is recorded. Rick started the recording, and this is AnCan's low and intermediate group. It's January 12th, 2026. So, I want to welcome all the new guys that are here. We do have multiple prostate cancer groups. We have an active surveillance group, a high-risk group that deals with high-risk disease and recurrence, as well as a gay and bi men's group. This particular group focuses on trying to determine a treatment path. So we don't discuss recurrence in this group. So if you're someone who's had prostate cancer and you've had a recurrence, then we would urge you to attend our advanced group. So currently we have several sponsors that we'd like to thank. Those sponsors are Bayer, Novartis, Myriad Genetics. I think we dropped Myriad Genetics, or they dropped us, right, Rick? I'm sorry. Bayer, Novartis,
yes,
Helix,
they disappeared.
Blue Earth, Diagnostics, and Foundation Medicine. So we will say that the views expressed in these recordings are solely AnCan Foundation's. They're the views of our of the moderators and you guys, the participants and your peers. We don't give medical advice because we're not doctors, though we may have some doctors in the group, and those doctors are your peers. I'm sorry. We don't accept sponsored promotions. Those sponsors sponsor us so that we can continue to do the peer-to-peer support groups that we do. Any drugs or protocols or devices that we discuss during these meetings, they're based solely on anecdotal or peer discussion, and we're not promoting them. They happen to be something that is used in the treatment of prostate cancer or the diagnosis of prostate cancer. And finally, we urge you to discuss anything that you hear in these sessions with your medical provider and your own medical team. And so that all being said, we are going to start the meeting with our new guys. I think Brian Hanley in Seattle.
Yes.
So you said you've been to another AnCan group before. Was that active surveillance, you said?
Yeah, I went to active surveillance last Wednesday.
Okay.
Yeah. It was really good.
They urged you to come here?
No, I just been kind of watching a lot of your guys' videos.
Okay.
I feel like this is the right place for me to be because there's a lot of good information.
So in the active surveillance group, did they query you about your disease, your diagnosis, and where you are currently?
Yes. Yes.
You want to give us a little of that background here?
Okay. I'll try to make it really short. Well, kind of short here. So basically, started getting my PSA about 5 years ago, 3.3, 3.8, 2022, 2024. And then it kind of crept up to 4.5, January of 2025. Then it went to 5.5, May of 25, and kind of and we just started kind of I basically started having peeing problems. I couldn't pee.
Yeah.
And it got worse and worse and worse and worse. In the last 2 years, I had to use a catheter. So I've been self-catheterizing for 2 years. I had all the digital rectal exams. They all looked really good. I had a camera up my bladder. That looked pretty good, but that was about 2 years ago. Ultrasound up there, that looked pretty good. Everything looked pretty good except the PSA, but they said, let's not worry about it. Too bad. But the peeing got really, really bad. And in the last year, sorry, go ahead.
They didn't think you had an enlarged prostate. They didn't mention BPH.
Oh, yeah. Yeah, they did. And I did get all my care through the VA. They've been really good. VA healthcare. I had BPH. Okay. So I had BPH. That's what I was diagnosed with. And so I was feeling good about that. But I was still on the edge because I knew, I don't know, man, something just ain't right here. So I couldn't pee basically for 2 years. Had to self-catheterize and 5 times a day. So back in May, May 1st, I had an aquablation, which most of you guys probably know what that is, where they go in and remove part of the prostate so you can pee. And I can pee good now. I mean, I pee great. Everything went perfect. I said, man, this is great. So they, with what they pulled out of the prostate, they did a biopsy. It's the only biopsy I've ever had. And they said, remember, this whole time, it's unlikely that I got prostate cancer. Oh, you know, in August, I did have an MRI. I had an MRI.
Okay.
And a PIRADS 1 and 2. 1 and 2. And it said with PIRADS 2 said with nodule without capsule. And
so the material they checked after your aquablation, did they say that showed prostate cancer?
With the MRI back in August, they said unlikely to have prostate cancer. So then that was in August. Then in May, I had the aquablation. And in May, when they took the sample, they said, you have prostate cancer, you have 3+4. And so it's a 7. And they said, I have pattern 4, I got 10%. I have P&I present, but none of the other stuff, no IDC, crib form, or LVI, but I do have P&I. And they said the doctor took out 20% of my prostate and 70% of it was tumor. But 3+3, and then the 4% was only 10, or the 4 was only 10%. So that's kind of what I was like shocked. I was just like, no way. Because all these years I'm thinking, nope, it's BPH.
Right.
So I'm going back in 2 weeks. I'm doing a PSA test this week. Haven't done one for a while, 6 months. And then I'm going to go back, and I'm not sure what to do. Do I got to do another biopsy? Because the only biopsy I've had was the one where they pulled the stuff out.
Right. So you said you had an MRI and they showed not a nodule, or was it plural nodules?
It says multi-planar high-resolution T1, T2, and DWI sequence obtained through the prostate and pelvis on MRI scanner. Before and after. It said multi-panoramic maps. It's PIRAD assessment for DWI score 1 with no signal abnormally. And that was in the perineal zone. In the transition zone, I don't know the answer to your question, so I'm reading it. In the transition zone, assessment for T2W is a score of 2 corresponding to homogeneous circumcised nodule without capsule. And then everything else appeared normal.
Okay.
So I think
Stuart,
that's
you had a question?
Hi, Brad.
Hi.
Have you had an MRI since you had the aquablation, or it's the only MRI before?
That was the only MRI before.
Oh, the MRI was August of 2024?
No, 2025. MRI is August of 25, and the aquablation was October of 25.
For some reason, I wrote May for your aquablation.
Aquablation was May 1st. I'm sorry.
So you had the MRI after the aquablation?
Wait. No, sorry. I'm sorry. I had the MRI. Oh, man, I'm sorry. No, I had the.
That's all right. Your MRI was in 2024?
Yeah, no, the MRI was on August 6th of 25. Oh, I'm sorry. August 6th of 25, and the aquablation was October 1st. October 1st. How could I forget? It was just 4 months ago.
That's all right. So yeah, the aquablation was after the MRI. So you haven't had, as Stuart asked, you have not had an MRI after the aquablation.
No, I've done nothing.
And you've had a PSA post aquablation?
No, I haven't done any PSA after the aquablation. I'm doing one this Friday. They told me to wait like 3 months. And I'm going back to the urologist in 2 weeks. So I'm going to do a PSA in about 5 days from now, and then go see the urologist.
Well, I think Stuart's. If your point is, Stuart, that a PSA is called for and possibly another MRI, I would agree with that. Because you had the MRI before the aquablation, and then it could have. I don't know what sections. I'm not familiar with aquablations, so I mean I know what they are, but I'm not real familiar with them. So I don't know what areas they would have used it on. I'm assuming around the urinary tract, right? So.
Yeah. Oh, and the other thing is that when they pulled out the thing, they said they took 20% of the prostate. They said 70% of that was tumor.
Right.
Yeah, I think it's around the urethra, isn't it? The transition zone. That's what I was reading.
Yeah. So.
But I don't know.
So I would think that another MRI would also be a good call, so that they could further image where you may have something else that shows up. And definitely, if they are talking about a biopsy, other than what they did on the material from the aquablation, then I would have another MRI before you got a biopsy.
Okay. They're not talking about a biopsy, but
Right.
and I don't want one because I'm afraid of them things because of the needle seeding or whatever you call it. I mean, I hope I know I'm wrong because everybody says I'm wrong, and that's good. I just don't know what to do when I go see this neurologist in a week or two. I'm going to actually see the one that did the surgery, and then the same day I see the one at the VA hospital. I'm getting back plugged into the VA. They're going to take care of this. So but I don't want. If I don't have to have a biopsy, then I don't want one. So you think
Right.
an MRI?
So you still need to talk to your doctors.
Oh, of course.
So I personally, I didn't like biopsies, right? You're right. When I had mine was a long time ago, about 11 years ago. Feels like forever, but mine was a transrectal, so they're in there and they punch a hole through your intestine wall into your prostate, and you deal with all of that. Now, the perineal, a transperineal biopsy doesn't go through your intestine, so most of the evidence points to that being a better method and an easier method to recover from. So, and there's less chances of infection from the the involvement of the intestinal tract. So, but if you go back to your doctors, we got a couple of hands raised, so I'll let your peers ask you some questions. But if you go back to your doctors, my first caution is, and this depends on doctors, but if they say you have prostate cancer, we want to take your prostate out, say slow down. I need another MRI and I need a biopsy. So
yeah,
that's what I would do if I was in your situation. I'm not giving you medical advice, right?
No, I know.
So
course
let's see what your peers have to ask you. Lost track of my mouse. Albert, I think you had your hand up first.
Yeah, I was afraid of biopsies too. I had one it was transperineal, but it was done in office, and I was encouraged to do that and told that something like, I don't know, I think the percentage given was around 60 to 70% of patients where I was going did in office with no sedation. So you're fully awake. It's just sedation in the area of the incision or whatever they do to get through the perineum. But I didn't want to do that again, so I opted for a surgery room under what they call pretty much a twilight, similar to colonoscopy sedation. And it was seamless. It was easy as pie. You go in, you lay in a bed, they give you an IV, you wake up and nothing hurt. And it was, if I can, I'll never go back to in office because it was brief, sharp pain, but it was brief, but it was sharp. And I didn't like it and I dreaded doing it. So I had to get surgical clearance to be able to be allowed to be sedated for my heart. I don't have a real bad heart problem, but they wanted that. But once you get clearance, apparently you can go into the operating room and they'll do it under general anesthesia. Again, I did mine transperineal. I don't know what the protocol is for transrectal, if that can be done under sedation like that.
Personally, I'd say avoid transrectal. I didn't have any pain with it, but it was extremely uncomfortable, I would say. David in Portland.
First off, I want to second what Bill said. Transperineal, far superior to transrectal. Transrectal has a risk of sepsis, a small risk, but it's still there. Transperineal doesn't have that risk. It also provides better access to certain areas, a certain area of the prostate that transrectal can't reach very well. And I also agree with Albert. I did mine in an operating room, slept right through it, not a big deal. But one thing they didn't mention that's really important is that the biopsy should be MRI guided. There should be an MRI taken first, and they use that MRI as an overlay so that they can target the tumor or whatever they're trying to hit, as opposed to no MRI guidance, which is just literally shooting in the dark. Okay. The other thing I wanted to mention or ask is, now are you just seeing a local urologist, or it sounds like you are? What you now know you have cancer. You're in Seattle. You got Fred Hutch right there. That's
Yep.
the place to go for cancer.
Yep.
Your local urologist is the guy who at 9:00 a.m. does a vasectomy, and at 10 o'clock does a bladder exam. He does not know as much about oncology as an oncologist does, and that would be a smart move, I think, to consider going over to actual genitourinary oncologist rather than just a garden variety urologist.
Okay, thank you for that. Yeah, I knew the Fred Hutch was right there, and the doctor at the VA said, hey, if you end up having cancer and it's something weird or whatever, I'll just send you over to the UW or Fred Hutch, which is kind of right there. So I feel like that's a good place to be. I also got heart issue. I had a heart valve replaced about 2 years ago, so I don't know if that matters. They put an aortic valve in, but I mean, I'm doing okay with that. But I know I hear people talk about that. And then the other thing is the transperineal. I asked both of these urologists, and they said they don't do that. They do the transrectal. So I don't know what to think about that.
You need to, well, unfortunately, a lot of urologists do the old school way, but there are ones, I'm sure you can find in Seattle, somebody at Fred Hutch or somewhere else who can give you, a more up-to-date biopsy.
Okay,
And
thank you.
it's definitely worth looking for. I had to do that. My first urologist didn't do transperineal. I requested it, and he flat out refused to do it. So I just did a little research and found another local urologist who would do it that way.
Don't be afraid to. I mean, if you have the means and your insurance covers it, don't be afraid to go outside of Seattle. I mean, if you want to get a treatment that you want versus one that your doctor wants to push on you, you know what I mean?
Oh, one last question: does it sound like I need a biopsy? Because they only biopsied what's inside. Does it sound like I need one of those?
I would definitely say before you go any further with treatment, if they want to talk about treatment, be it prostatectomy or radiation or anything, that you should get a biopsy.
Okay. All right. Thank you, guys. Appreciate it.
Gil has a question.
Yeah, Gil.
No, I'm just going to comment on my own personal experience. I would go by what they say as far as recommending a biopsy, because you did have tissue obtained, which in essence is a biopsy. And you didn't have any lesion on MRI, right? Oh, you did have a lesion on MRI.
Is that what that is? I think it is, one lesion.
Okay. So, I wouldn't say hard and fast. I would go by what I would ask them if you need another biopsy and have them explain the rationale. If they say, no, we can go on what was already done. As far as transperineal versus transrectal, I've had both. And in general, with procedures, which includes colonoscopy, endoscopy, I don't have sedation. I just sort of, and it depends on your pain tolerance and it depends on your psychological makeup. I just kind of go in there saying, okay, it's going to hurt for a while because they're giving local anesthetic, but I can put up with it and put my mind someplace else. But the advantage for me, like with colonoscopies, which I'm sure a lot of you have had, is when they're done, 10 minutes in the post-op area, and then I go home and I actually drive myself instead of sitting there and having somebody else drive and all that complicated kind of stuff. But anyway, that's just my, and as far as transrectal versus transperineal, if they give you antibiotics on the transrectal, the incidence of infection is pretty much the same, like less than 1%. And so I would take other factors into account. For me personally, it was who could do it, was it convenient? But I had an opportunity to do go see somebody else for a transperineal, but I stuck with the same person who had done the last transrectals, doing the fusion biopsy. So, I mean, I wouldn't go hard and fast on any of these. I think I would take into account that some are, for me, there are pluses and minuses to everything, and I wouldn't be rigid about any of these decisions. I would just ask a lot of questions, and you know, you're still in the 1% risk of anything bad happening with either type of biopsy if you need one. You know, and I would go based on whether they thought they got enough tissue in the right areas from the aquablation or not.
Yeah, so I mean, and that's why we talk to our peers, because we all have our different experiences. But Gil, I respectfully would disagree on the requirement for another biopsy, because he had an MRI and then an aquablation, which removed part of his prostate. So I would say another MRI and another biopsy, because some of the material may be gone, but there may be other areas that will show up afterwards. So.
Oh, I'm not saying
again, my opinion.
I'm not saying he shouldn't have one. I'm just saying he should ask the pluses.
Oh yeah,
if they
get his doctor's
they,
rationale, but I would ask for one myself. You know,
okay.
I think
regardless of what my doctor wanted. So.
I think I'd take a. Sorry.
Go ahead.
I think I would take a little bit of a step back and start to approach this from the question of, do I have prostate cancer? You know, and start with looking at the PSA, possibly looking at some of the other pre-MRI tests. There are a couple of really good tests that can indicate likelihood of something being there, and really try and answer the question of, is it still there, before you worry about whether or not you need a biopsy.
Okay.
Good point, Stuart.
Thanks, Stuart.
I mean, because you've had a form of treatment, right? So it was for the BPH, and then they discovered some of the material. So we tell several. I've heard it again and again in these groups that we've had guys that had BPH for years, had one of the procedures like the Roto-Rooter and other things, and some of the material. My own brother, the material showed prostate cancer, but one individual that was in this group for a year was told he had prostate cancer based on a TERP, and wanted to do active surveillance, and then he went back and they said, well, we can't find anything. Wow. You don't have prostate cancer anymore. So, wow. But once there was prostate cancer in his prostate, so the chance that he will probably experience that again in his life. My brother's on active surveillance, so he found 3+3, and he said, well, he asked me, and I said I would go on active surveillance and just get your test and don't worry about it till something else happens. So I'm not saying that's your situation, but we've seen that situation, right? Yeah. So we've seen people be treated for BPH. They found a little bit of prostate cancer, and it it wasn't anything they had to address immediately. And as Stuart said, there's other ways to check for things before you go down the more drastic paths. So, but it really looks like we got to wait till you get your PSA and hear what your doctors say before we discuss it further, right? So.
Okay, thank you. Thank you.
All right, well, come back. You're welcome anytime.
Thank you. I'll be here.
You're welcome to go to active surveillance also. I mean,
Okay.
you can go to both groups and listen to what the guys say about what's going on. So.
Should I request a DECIPHER test or whatever they're called?
DECIPHER tests don't hurt.
Is it going to help?
Is it going to help?
I mean, is it going to tell me?
You haven't had a biopsy, right?
I had one when they did the aquablation.
Which was how
They
long?
biopsied the material that was removed by the aquablation, right? So, Rick, did you want to follow up?
No, it's fine.
Okay.
All right, thank you guys.
Well, Brian, just on the test, you're right. You're sort of jumping ahead.
Okay.
Focus on the initial question of, do I still have prostate cancer? Can they find any sign of it? If they get to that point and you get to a biopsy, there's plenty of time to ask for the tests then.
I may not even have it.
Right.
Wow.
That's good. That's a good attitude.
That's better every night.
Keep checking.
Oh, we'll be on it. Thank you. You guys are great.
Yeah, I'd also suggest you attend our veterans group. Have you done that?
No, not yet.
Okay, well, the next veterans group is on the 20th. It's not in this room, it's in our other room. Are you on our distribution, Brian? Have you signed up?
Yes.
Brian's on our mailing list. I don't know what he's.
And
Right.
I've been watching a lot of your guys' videos. I did watch some of the veterans group stuff and active surveillance, and I watched some of this stuff today. I've kind of been watching it. So.
I'll just check and make sure. I'll check right now. I'll make sure that you get that reminder, and they will help you greatly in terms of whether you're getting all the benefits that you're entitled to and how best to arrange for community care.
Okay. And I use community. I actually use community. That's who did the aquablation. I was at the VA, and the VA didn't do that procedure, so I did do community care. That's how that worked. But thank you.
Yeah, he's signed up for all the reminders, Rick. So. All right, so we're going to move on to the gentleman that came in last time. I can't find my sheet. Frank.
Yes, thank you. I had to take this off of mute. I was in this group initially when I was diagnosed with prostate cancer, and I was redirected to the active surveillance. So that's where I've been spending most of my time. And now that I've decided to move forward with the treatment, I wanted to join this group. Just quickly, I was diagnosed with prostate cancer in May of last year. My PSA was at 6.4, and my urologist did a biopsy. It was a transrectal, not targeted, because I didn't know any better at the time. But from that biopsy, it came back as intermediate unfavorable through the LabCorp, which is the insurance my company uses. And then subsequent to that, per recommendation of the active surveillance, I sent my slides to Dr. Epstein in New York, and he and I talked, and the results of that biopsy, the initial one was I had 3+3s and 1 3+4. Dr. Epstein found one additional 3+4. Unfortunately, I was hoping that maybe he would downgrade the one that was found before that. Talking to Dr. Epstein, he said I had a slow growing prostate cancer, and I could probably take up to about a year to decide what I wanted to do, which included doing active surveillance. In addition to those tests, I had a prostate ID done that came back intermediate unfavorable. I had a DECIPHER report done by one of my urologists, and that also came out as intermediate unfavorable. I did the AI MRI as well, and sent that to the last urologist that I talked to. He didn't have much to offer from that, and I guess really because he's not that familiar with the technology in the MRI. He said it was helpful, but he didn't add much more to that. I've visited with, so in thinking about going forward with some kind of a treatment plan, I started researching different options, and I talked to 2 radiation doctors that do IMRT. I visited with a surgeon, a urologist as well, and I've seen 3 different urologists as well. And after all of that analysis and talking to the doctors, I also looked at proton therapy as another option. And after all that research, I've decided to move forward with proton therapy down in San Diego, California, because there's several of them throughout the U.S., but they're not as prevalent as other medical facilities. So I've met with Dr. Rossi at California Proton. He showed me in the MRI the tumor that he's most concerned with is about 1.5 inches large and very close to the, I guess the lining or the cell. I'm not sure what it's called of the prostate, and he was concerned that that could get into the bladder.
Capsule.
Capsule, thank you. Yeah, and he's concerned about that. He said if you're going to do active surveillance, you should get another one done now to see how fast it's growing. But he said eventually you're going to have to deal with that because it's I guess risk and it's going to continue to grow, which I guess is kind of consistent with what Dr. Epstein said. Most of these doctors that I was seeing, they were pushing for me to do treatment and not do the active surveillance, which I kind of kept pushing off. But I've decided to do the proton therapy. I started out with Loma Linda and working with my insurance because that was the other big challenge was trying to get insurance to coverage. Because if you go out of pocket, it's about $100,000 or $90,000. And I was thinking of going over to Social Security, Medicare, because it would be covered that way. I was finally able to get the insurance to approve the proton therapy, but they referred me to the California Proton in San Diego as opposed to Loma Linda. And so, which I'm okay with that because it's apparently a newer technology. It's pencil radiation. It's a little more precise. And I guess in my own terms, the layman's part of it is that the proton is safer or less impact on tissue outside of the prostate as opposed to the IMRT, the photo versus the proton. And the way the proton, as I understand it, and I'm not an expert, but I've done my research and talked to people, it goes through and hits the prostate cell, and once it hits the tumors or the cancer, it diffuses. It doesn't go beyond that. And as opposed to the IMRT, which can have more severe effects on other areas outside of the prostate. So right. I talked to Loma Linda provides a list of patients that they've treated. I got a list probably about 100 individuals, and I either talked to or emailed over 15 individuals, and they all had a lot of good things about the proton therapy, and the side effects were very minimal, if any at all. Not to say that that might be the case for me, but of those individuals that I talked to, one of them talked about some rectal bleeding and some urinary bleeding, and the urinary went away after a couple of weeks or a month, and then the rectal, they had to go in, his GI doctor, and treat some scarring that had occurred. So I also read a book by an individual named Robert Marckini, Marckini. It's titled "You Can Beat Prostate Cancer and You Don't Need Surgery to Do It," and he's very comprehensive, and he did a lot of research on his own, and he covered all the different treatment options, and he recommends looking at proton therapy. And I communicated him via email, and because California Proton gives you this document you have to sign off with all the side effects that you can get, and I sent him an email asking, well, there's all these side effects that I'm being asked to sign off, but all of these patients and all that.
So Frank, yeah, so you've covered everything that you're thinking of doing, and it looks like you've pretty much settled on proton therapy. So what can we do to help you, or what questions can we answer?
Oh, if anyone is familiar with proton therapy or has done their research, I'd be interested if
we got several hands up.
I'm sorry?
Rick, we have several people with their hands up. Rick, you put your hands up?
Yeah, there are people in this room who have done protons, so you can talk to them. The bottom line is, if you don't have a financial interest, if you're totally independent, there's absolutely no evidence that proton therapy is any better than photon therapy. None. And if you can find it and present it to us, we'd be happy to send you an AnCan t-shirt or an AnCan sweatshirt, but there is no evidence. Now, people who have proton machines will tell you there is. The bottom line from an old study from 2013 that's still good is that with proton, you are more likely to have gastrointestinal side effects, and with photon, you're more likely to have genitourinary side effects. So anybody who tells you that there are less side effects, we can send you that research. But you may choose not to believe it, but there is absolutely no evidence at all that proton therapy is any better than photon therapy.
And Frank, I'll say that I had IMRT radiation over 10 years ago, almost 10 years ago, and I had I had problems with my intestinal tract, and I had problems with my bladder and urinary tract from the radiation treatment. And I was at a center that was, highly respected, that had all the good write-ups and good reviews. And it was an established treatment, right? So there's side effects from any treatment. Yes. Who's going to get which side effects is really unknown to doctors. There's not a lot of studies that specifically say that this particular patient's going to get this kind of side effects because he has X, Y, or Z. Medicine's not really there yet. So
yeah, and I didn't mean to say that I won't have side effects. It was just that in looking at the different options, I just feel this is probably the path that I'm most comfortable with.
Well, a couple other guys want to ask you. David, you had your hand up a minute ago.
There is a test, but I don't know, maybe somebody else knows, if the Prostox test works for people planning to have proton therapy. There's a genetic test you can do. You just spit in a tube.
I don't think so. I don't think so, David. It's only for SBRT photon.
Yeah.
And I've just put an article. This is actually a more up-to-date article that comes out of a lengthy study. I think it was last year. Let me just see. When was this? Well, that's great. It says when. Anyway, I just put it in the chat window. This comes out of the Journal of Clinical Oncology.
March 2024. March 2024.
March 2024. Thank you. Yeah, I see it right at the top. March 2024, and that will that concludes what we're saying. I mean, it may be a preference. We can't argue with that. You know, you got your insurance to do it, but don't think that you're getting anything better with proton than you would be getting with photon.
Yeah, and I would add Marcini is not providing, he, like me, I'm biased toward the treatment I had. He's biased toward the treatment he had. So you're not getting an, even objective assessment from a proton advocate. And it seems to me, just from the experiences I've had reading things put out by proton people, they are really into proton. It's almost like a little cult within the patient community. I mean, they're much more enthusiastic about proton than anybody, but I know of people who've had proton who've been hurt and, who have, so it's not, devoid of risk. Everything has risk, as was already said.
The reason is oftentimes because they've spent a lot more money to access the proton. And so they have an inbuilt bias to justify the additional money that they've spent.
Yeah.
And that's Rick, why, there was, what was his name? Proton Bob. I haven't heard of him in ages, but Proton Bob was like famous. And you basically can't trust, but go ahead to some of the other people with their hands up.
All right, John, you had your hand up? You're muted.
Yeah, basically, I think it's the study, basically debunked proton being superior in the story. It's not superior between proton and photon, so it was just a landmark.
What was the name of the study, John?
Hold on, let me see. I'm trying to look it up. I think it's the PARTIQOL. No, that wasn't the study, but what was the name of it? Yeah, I'm trying to look it up. But basically, no improvement in urinary outcomes, no improvement in bowel outcomes, no improvement in sexual function, no difference in cancer control, no reduction in meaningful toxicity.
If you can find the name of the study, could you put it in the chat window for us?
Yeah, it was a big. It was released last year, and that was a relief to a lot of people. I had MRI guided photon, and I'm 13 months out with absolutely no side effects. Urinary, sexual, nothing. So.
Yeah, John, I think that's the study that I just posted that was released on March 20th, 2024.
From JAMA. It's in JAMA.
Right. Gil, did you have something you wanted to say before you sign off for dinner about proton and photon? You muted yourself.
Basically, to echo what everyone said, and that a lot of the data was based before MRI guided, where they actually have tighter margins, so less exposure to bladder and bowel, and also using rectal spacers to get the bowel away from the prostate. So you can't go by data from years ago when there's new technology. But anyway, so I would throw in with what everyone else is saying.
I even opted out of the spacer. Dr. Nagar told me,
So from what I'm hearing people say, Frank, is they don't feel there's any difference between the two, so you'd be well served for choose either one. if you choose
Yeah, I
radiation
kind of
as a
ran
treatment
into
path.
that in the research. I saw that as well in my research.
When did you think that you were going to pursue this treatment? When you might pursue it?
I'm going to, at the end of the month, go down there for some prep work, and it'll probably start in mid to late February.
When Dr. Epstein did your second opinion, did they give you a reading on how much cancer was found in your different samples? The 3+4s?
Well, Dr. Epstein, he pretty much repeated what was in the original, except he found one additional sector that was 3+4.
But you know how much cancer was in the samples, or how big they were, percentage-wise?
I have to look it up. 10%.
10% of one particular core, or 10% of each core? Or?
Of one core.
So you had two cores, one 3+3, one 3+4, and then Dr. Epstein identified another area that was a 3+4.
Correct.
Is that what you told us?
Yes.
And 10%.
The whole idea was to downgrade it.
Yeah, that's what we all hope for when we go for a second opinion, right? That it's be a more favorable outcome. But,
yes.
Okay. I mean, I can't give you medical advice.
Right.
And I understand a diagnosis of cancer like pretty much like everybody in this room does, right? So, I don't know. I would think more toward what he said about it being slow growing, about it being a fairly small percentage before rushing into a treatment. So, but you're doing all your homework, and it seems like you're pretty confident that the photon or the proton will be what you need.
Right.
Yeah. And remember, mine's a little bit of hindsight, right? My treatment's behind me. I don't have treatment regret because there's no sense in having that because you don't know what would have happened if you chose any other treatment. So.
Sure. Well, I hope I'm in your position.
There's no reason to even think about it.
Right.
So. Anybody else have anything for Frank?
Thank you.
Okay, Frank. Well, yeah, definitely come back and let us know if your doctors say anything else or if you want to discuss this further.
Will do. Thank you.
All right. We're going to move on to Steve in Cape Cod.
All right, thanks. So quickly, 66-year-old veteran, 25 years in the Army, had BPH for probably 20 years.
Sorry to hear about the Army part, but that's all right.
You're not a Navy guy, are you?
No.
Oh, okay. All right. Anyway, 20 years BPH, was on finasteride for about 5 years. Stopped that in 2022. And then I was no real issues except that. And then in August 2024, my urologist did a digital rectal and found a little lump. So that's concerning. Let's do an MRI. So did that at a PIRADS 3, small lesion, 0.6 or 6 millimeters, I think is the right term. Small, decent sized prostate, 33 cc's, PSA density of only 0.06 at that time because my PSA was like 1.97. So that's why the PSA was not a good marker. If he hadn't done the digital rectal, would not be sitting here right now. That led to a biopsy, transrectal, and initially the readings from the local urologist was a 4+3. Since I'm in the Boston area and Dana-Farber is pretty close, I said, I'm going to go get a second opinion at Dana-Farber. They reread it and they said, no, it's a 3+3. No definitive component of 4 identified. 7 out of 13 cores were 3+3. So I went on active surveillance, checked back in with my doctor there, and he said, let's do another MRI in June, which I did. And there was a PIRADS 4 in that one in the LPZ zone. I guess that's lateral peripheral zone, consistent with that tumor that was identified in my biopsy. No evidence of any outside the capsule. Just to check it, the guy let me do a PSMA PET scan, and there was nothing, no evidence of anything outside the prostate. He wanted to do a confirmatory biopsy, so we did one in August with transperineal. That one showed out of 7 zones, 4 had cancer, 3+3, and 1 now was the 3+4, the LPZ base, with 10% of the tumor cancerous with a pattern 4 and PNI. Because of my dad had prostate cancer in his late 60s, made it till 89. Don't know exactly what caused his death, but he died of metastatic cancer all over his body. So I don't know if it was, I assume it was from prostate. He was treated with brachytherapy. Because of that, I did genetic testing. Genetic testing shows that I carry the CHEK2 gene. So that another concern. And the DECIPHER that I got out of the last biopsy puts me at a 0.54 intermediate risk. So that's where I've been on active surveillance. And now I have a call with my doctor next week. And I think he is feeling that I should probably start thinking about taking some action because of the DECIPHER, the CHEK2, and my dad. The good things, obviously, I've got going: low PSA, 3+4, and low density. So I guess a couple of my questions is, I've just read this book, The Invasion of the Prostate Snatcher by Dr. Schultz.
Yep.
Or I guess I'm saying I'm halfway through it. I haven't read it all. I'm just halfway through. And it's really making me question, do I need to do anything? And if I've got to do something, Dr. Schultz certainly is not a big fan of surgery. He is a bigger fan of radiation, if anything. And I guess I've been leaning toward surgery as I've thought about this for a couple of reasons. My thought process being, because I was a 4+3, 3+3, 3+4, I'd really like to know what it is. And the only way I can do that is get the thing out and have it checked. And then what I've learned through research, and you can validate this or not, doing the surgery first, then radiation second if it recurs. I think I have a higher chance of recurrence because of the CHEK2 and the DECIPHER. So if I do the radiation first, and then I have to go to ADT if it comes back, which I guess I would say of the 3 is the last thing I want to do. So I guess my question is, are people fans or not fans, or believe in this guy Schultz and what he says? And over treatment is such a prevalent thing now. Should I push back and say I want to keep on active surveillance, or when do you guys feel like you have to make that call? Because I obviously don't want to get outside my prostate. I don't want to get in my bones. So, but I hear everyone says, "Oh, it's slow growing. Don't worry, you got time." So just trying to find that answer which I know is not easy. And I have other questions, but I'll just throw them out there. And then, so if I did surgery, I've had an inguinal hernia 10 years ago. Does that mesh have any issues on surgery? Are there significant concerns with blood clots? I've never had blood clots, but I have terrible veins in my legs. Radiation, I was interested in hearing John from New York saying he's got absolutely no side effects from radiation. That's pretty encouraging. And then lastly, I heard everyone talk about this Dr. Epstein getting second opinions. Is that easy to do? And maybe you could help me understand, how could I get an opinion from Dr. Epstein? So those are my questions. Sorry to throw them all out there at once.
Yep. So do you know where the chat window is on the?
Yep.
If you look in the chat window, there's a pin button at the top with a red dot on it. And I think you were here early enough to see these pinned, but Dr. Epstein's information is
Oh, I see it. Yeah.
is at the top of the chat window.
And he'll just take a call from some guy in Massachusetts and talk to me.
Yeah, so you can go to his website and it gives instructions on how he wants to process your stuff. But you could definitely try to call him. He does answer the phone often. So
Okay. Is there a fee for that?
there is a fee, yes, and sometimes it's covered by insurance and sometimes it's not. It depends on your insurance plan. So
Okay. Well, that's interesting because I tried to call Dr. Schultz today from the guy who wrote this book out in California, and they said, "Yep, yeah, you got to be $750 to join his practice, and then $1,250 to have, have a consultation." So I haven't selected that one yet.
It's 500 for Epstein.
What was that?
It's 500 for the second opinion from Epstein.
500? Okay.
Right. So here's, I think, our point on the second opinion, Steve, to address this one. First of all, you can't get anything from him until you send him your slides. So there's not much point in calling him. Did we lose you, Steve? Did you just come back in?
Yes, I'm sorry. A
That's
call
okay.
came in.
Don't worry about it. So here's what we're saying. There's not much point in trying to call Dr. Epstein until you've sent him your slides. There's no point in calling him just to have a chat about what should I do. You've got to send him your slides. He's got to look at your slides. Now, we feel there are maybe 3 pathologists in the United States who have the very best eyes. 2 of them for sure, Dr. Epstein and Dr. Zhao, who I believe are pinned at the top. We work with all the time. They know us well. Dr. Epstein charges $500, but it should be covered by your insurance. Dr. Zhao is a little less expensive. I don't know. Dr. Zhao was trained by Dr. Epstein. They both have very, very trustworthy opinions, a lot more trustworthy than what you'd get from your local guy or even from Dana-Farber. So if you want to know definitively what was seen in your last biopsy, you've got to get your slides sent to either Dr. Zhao or Dr. Epstein. He will talk to you. Both of them will talk to you, but after they've seen your slides. So, don't be calling him up and say, "Oh, I heard you would talk to us on the AnCan," and he'll say, "Yeah, sure, but you've got to send me your slides." So that's the answer to your first question.
Okay.
The next question, which is invasion of the prostate snatchers. Yes, I've got the original copy. There is a new copy. Back in 2023, we did a webinar with Dr. Schultz, and I'm just about to post that. And I just put it in the chat window. You can go listen to that webinar, see what Dr. Schultz had to say. As far as our opinion on Dr. Schultz, he wouldn't be my doctor of choice, largely because I think he has some significant biases, and so you don't really get a fair opinion. I think that he does, his videos can be excellent, but some of them are off base. And how much weight would I put on what he says? Well, if you are inclined towards surgery and that's what you want to do, and there's good reasons, yeah, there's a lot of times when surgery is good. Can you do more radiation treatment after radiation? Yes, you can. That's it's a line that a lot of surgeons like to use to try and get you to go to surgery. What you really need is a surgeon and you'll find them at Dana-Farber. There's a couple of good ones there who are even-handed, and they're going to tell you what they think would be best for you given your situation. Now, your check 2 definitely does impact. It does make you a little more inclined towards getting prostate cancer, and I'm not too sure about the recurrence. Have you signed up for? Are you signed up on our website, Steve?
I think so. Yes, that's how I got notice of this. Yes.
Okay, so just let me know your last name or what have you. I'll make sure that you are added. We have a group we just started for inherited mutations, and the guys on there are pretty knowledgeable. David is in that group, and discussions about the impact of certain mutations and how they affect treatment. We'll also add you to a distribution we have called BRCA Brothers, which is just now, once again, prostate guys who have inherited mutations of all types, not just HRR, BRCA, could be DDR, could be a Lynch, whatever. But it's very helpful, and you can send a note. I'll put you on that. Distribution, and you can send out a note and say, what does anybody know about check 2 and radiation treatment? David hasn't put his hand up, but he may know a little bit about it because he's done a lot of good research. What were your other questions?
Oh, just Rick. My last name is Carter, Carter. Just so.
Got it. I'll find you.
Yeah. Okay. I guess when I was thinking about the surgery piece, does a hernia get in the way with a mesh? Side effects of blood clots and all that stuff? I'm sure the surgeon will tell me, but I haven't asked them that yet.
Yes. So depending on the extent of the mesh and what they used and where it is, it can make robotic surgery very, very tricky. So yes, it is definitely a factor. The other thing we'll do if you're not signed up is we'll sign you up for the veterans group, because as I said before, they can be very, very helpful to you in terms of benefits, treatment, all kinds of different stuff. So hopefully I covered everything. I'll give someone else a chance.
I do have to ask, as a new guy, Rick, you're obviously, are you a doctor or are you just very experienced? What is your role?
I'm experienced.
He wouldn't be my doctor of choice.
Oh, okay.
I should put my camera on. Sorry, I've been doing other things here. My role is just to throw in a bit of knowledge. I've been doing this since 2007, when I had my own treatment, and I came up with the idea of creating virtual support groups back in 2010. And I've been working on developing virtual support groups one way and the other ever since then. Started off with the telephone, went to video chat in 2015, long before COVID. So
well, thanks for doing it. That's awesome. You're the founder of why we're here. So thank you very much.
Rick is AnCan. He is the founder of AnCan.
Oh, you're the founder of AnCan. Wow.
Yes, he is.
Yeah. Oh, well, I'm sorry to not know who you are. I didn't know.
No, it's okay. I mean, no, I'm not offended. Not in the slightest bit offended. I'm happier that we're going to try and get you to the right people. And I think if I was in your shoes, I'd definitely get reread. I would try and find. I don't know. It's not easy to switch urologists. Who are you with at Dana-Farber?
Dr. Adam Keibel. He's the head of.
Yeah, he's good. He's really good.
Oh, so I'm in good hands there.
Yeah, you're in great hands. We there's him and one other guy that we recommend, and that's based, by the way, on one of our advisory board members who's a a genitourinary medical oncologist at Dana-Farber. So you're with the right guy, and he'll be really fair with you. And you can talk to him about the implications of check 2. He should be helpful. David, do you know much about check 2 or not?
No, I've only focused on BRCA.
On BRCA1, huh?
Some of the research I've done it's still very much. I mean, to your point, says that there's a higher likelihood of getting it, but
Yeah, there is.
The longer term
So,
effect by radiation, they haven't got much conclusive evidence yet.
Yeah, I mean, the thing is that we know that some of these HRR mutations make you a lot more sensitive to radiation as well. And in fact, we discussed that. We had our very first meeting of our inherited mutations group last Thursday night. That was men, women, the whole, and it actually came up and it was discussed. There's a well-known BRCA medical oncologist in that group who carries the mutation herself, and she's very knowledgeable. And we did discuss it. I would say I'll get your email. We'll get you into that BRCA group, and then send out. Don't you think, David? Send out a message to all the guys in the BRCA group and see if anybody knows anything about check 2. You're muted. You're muted.
You're still muted.
You're still muted, David. You're gonna have to start again.
You caught me in the middle of looking something up about check 2. So I couldn't get to my mute button quick enough. If you'd like, I'd be happy to just fire off a message to that group, just asking if anyone knows about check 2. And
that'd be great.
Well, right. Thanks very much, David.
You do that, and then I'll make sure Steve gets added tonight to the to that distribution, and we'll also let you know when the inherited mutation groups are only once a quarter right now, but you'll know when they are, and okay. we'll help to educate you, sir. I mean, that's what we do, right, Bill?
That's what we try to do.
Right.
So if I could ask.
And let me just say, he's not in the air, he's not in the Navy, and he ain't in the Army, but he's a military man through and through.
What are you saying? You're Coast Guard?
Nope, not Coast Guard, Marine Corps, Space Force, Navy, or Army. So the other one, the better one.
Yeah, running out of them. Wow. All right. Well. We're all brothers in arms until it's Army Navy football day.
Little sibling rivalry.
Yeah. So I know I've taken too much time, but John, in your radiation story is great. Would you share again what type of radiation you had and how you have no side effects? That's awesome.
Yeah. Hold on. Yeah. I mean, I got diagnosed, I guess, in June of 2024. Did my research. Found this group, and went to Weill Cornell, had a transperineal biopsy because I refused the transrectal. And from there, a former moderator, Mark, put me on to Dr. Nagar. I was looking for Dr. Nagar at Weill Cornell, but he had left there and gone to Sloan. So I was one of his first patients. And just the MRI guided real-time imaging and targeting and gating really impressed me. But the machines the Meridian machines, I guess, went bankrupt, and I was disappointed. But then I found out that somebody bought them out. But then I found out there's a similar machine at NYU and at Sloan Kettering. And I found out Dr. Nagar was going there. I met with him, and guess the rest is history. It was basically 5 treatments, SBRT. I opted no fiducials, no spaces, empty rectum, empty bladder, which surprised me. And because the nurse says, no, you don't have to fill up your bladder. And then I questioned that with the third nurse when she was giving me the enema. And That's the only thing you have to do before. And basically, it was a non-event. I didn't even know the machine was on if it wasn't for the buzzing. And each treatment, depending on if you move or don't move, or if your bladder moves, they think everything was glued up down there because nothing moved. So I was in and out of the tube. There's some background noise. I was in and out of the tube for the 5 treatments within a half an hour each time. So
And why did you choose not to do the spacer?
Because there's issues with the spacer too. I guess Rick scared the hell out of me, but that's another story. Well, there's a lot. It could penetrate the I guess the rectum wall. There's issues with it. It's not as clean cut as they say it is. So I just opted out of it, and went back to Dr. Nagar, and I asked him, "Do I really need it?" And he looked me straight in the face and said, "No." But they offer it if you want to be. It's a personal choice. I just decided not to have it done because that would have been another procedure. They put me under. They injected. It's a small space between I think the rectum and the prostate. They got so things could go wrong. It doesn't go wrong, but I just opted out of it. And it's 13 months now, and basically. Actually, my urinary flow, I was concerned I would have stricture, but no, everything's good. I had
Well, that's a pretty good example of what we were talking about earlier. It just depends on the person as far as side effects. Someone might have gone through the exact same treatment and had urinary side effects. So
yeah, and then New York doesn't offer the Prostox, so but
no,
Dr. Nagar said he's not concerned about it, and 13 going on 14 months, basically a non-event for me. So.
All right. Thanks, John. And Bill, I'll turn it back to you. I've had taken enough time.
All right. We do have one person with their hand up. Govinda.
Yes. I just wanted to add that I had SPRT radiation about 10 years back in Sunnybrook Hospital in Toronto. And initially, there were some side effects for about 3 to 6 months. At present, after 10 years, I would say I'm 90% normal. I have no serious problems. I play tennis, I play a bit of golf, and I'm 82 years old now. I took my radiation when I was about 72, 73. So everything seems good for me now. So that is my 2 cents worth.
Yeah. We do have some people that want time, but I'll say one more thing is that I had more intense treatments with surgery and radiation and ADT, but 11 years later, I'm pretty much, I'm older, but I'm pretty much where I was prior surgery, right? It wasn't overnight, and I had some extenuating circumstances, but don't give up, keep going, and I'm back where I was. So minus the age-related issues, but
I'd like to just say my experiences were similar to John's. I had quite extensive radiation in July of this past year, and for 2 weeks afterward, I had significant urinary symptoms. Then on the 3rd week, they just improved by about 80%, and by 2 months, I had no more symptoms, and I still don't. I did have a spacer. This is my bias, I'm very pro spacer, but there are different kinds of spacers. There's the oldest brand, which is Space Or. There's a newer brand called Barrigel, which I think a lot of doctors would say is the preferred one. It's easier to apply, and so ask around. But I got it, and I'm glad I did get it. I haven't had any rectal problems whatsoever.
all right, we're gonna move on to some of the individuals that wanted time. I know, Steve, you said that you had to head out to do something. It's a completely different time zone there. Steve in Malaysia.
Yeah, I'm actually heading to California shortly. So quick kind of updates. I had a PSA read. It was 1.97. My last was about 4.33, and so that I think was impacted by a infection. So I kind of throw that one out. But it's sort of on a slow trend up, but you know, at least it's not exploding. So I'm seeing the guys at Stanford on Friday. They just ordered a DECIPHER test. I will get the prostate test results on the 15th, right before the consult. I'm kind of, I don't know if they do rectal spacers there or not. I heard your note on Barrigel, so I'll ask them about that. Based on my research so far, it seems like I'll be doing MR Linac and likely a course of ADT because I've got some adverse features, curviform and AIP / interductal borderline. So I know I need to do something. And by the way, thanks Rick and Stuart for all your help along the way. So I think based on what I've heard, that, you know, the space or type stuff is worth doing. I'm not sure if Stanford does or not. I'll ask them. I'm considering Orgovyx as an ADT drug. I don't know if anybody's had experience with it or can comment on it. No.
Yeah, I just finished up 6 months on Orgovyx, and I exercised vigorously the whole 6 months, and I had extremely minimal symptoms. I had a one nightly hot flash, and that was the only. It happened every night about 6:30 p.m. It lasted about 15 minutes. It felt like the room went from 72 to 88, not 108. In other words, it was just like a warm feeling, not a blisteringly hot feeling. I wasn't sweaty. It just felt warm, and then it went away and came back the next day. I definitely think the exercise plays a huge role in minimizing all ADT symptoms, whether it's Orgovyx or not. One of the things that'll happen is if you don't exercise, particularly weight training, you'll lose a lot of muscle mass. But the great thing about Orgovyx, though I've had one doctor debate me about this, is that once you stop taking it, it wears off fairly quickly. I stopped taking it in mid-September, and I would say those hot flashes ended around mid-November. I felt completely back to normal. I had a testosterone test recently, and it was at 600. Just 3 months after stopping Orgovyx. So you get back to normal fairly quickly on Orgovyx. I was only on it for 6 months, so that makes a difference.
Okay, awesome. I'm not sure you guys can answer this because I'm a little unique, but as far as getting prescriptions for it, Orgovyx, I don't think it's available in Malaysia from what I've asked my urologist and my RO. Any idea how normally you go about getting it besides just getting a prescription from the doctor? Because I guess the other thing was from some of the research I've done, they can start you before the operation or before the radiation. And if so, I don't know if I have to make a special trip or how to deal with that.
Well, I can tell you what I did. I started taking it 3 months before the beginning of radiation because it has the added benefit of it shrinking the prostate. And, smaller the prostate, now they can aim at a smaller target, and potentially less healthy tissue will get hit in the process. And so it has that advantage too. I got it directly from a pharmacy that works with the manufacturer. My medical oncologist is at OHSU, and she actually, or OHSU, got the ball rolling. I'm not quite sure how they arranged that, but it was mailed to me through the mail I didn't pick it up at a pharmacy.
Okay. Yeah, my sister actually works for the company that manufactures that, so I'll ping her as well.
Oh, she could just bring some home from work for you.
Yeah, I'll try to get it through customs then.
Yeah.
Have her get me some more too.
Yeah. Awesome. Okay.
Steve, did you say something about Prostvac?
Prostox.
I'm sorry, I
So
can't.
I self-ordered Prostox as an international patient because
Okay.
Stanford never talked about it, and a guy I know, Greg, he said that they never mentioned it, so he's having basically the same thing as me, but without ADT, starting in a week, I think. But so I
We've
think
talked about it on here so many times.
okay.
So
No, I'm doing it. So I just
yeah,
hope
I mean, when Greg says we haven't mentioned it, I don't know where he was because we've talked about it. We've had a webinar. You probably saw the webinar on it. God knows.
No, he said that Stanford didn't say anything about it.
Oh, Stanford didn't tell him. Yeah, I think we probably told him, but yeah, it works well. As far as the Orgovix, it's probably best to find out through your sister who's distributing it. If she can find out who's distributing it overseas. It is expensive. It's probably a better LHRH drug than any of the others. It definitely wears off quicker. I'd love to talk to the doc who doesn't think it wears off quicker. We've just, anecdotally, we've seen it so many times. The other thing is
from everybody.
You're only using it for 6 months or less. It's really not even worth worrying about. You'll get through it. I mean, I did an LHRH drug for 28 months. Bill did it for, 2 years or so.
2 years.
That's when you really have to start worrying that it's going to affect you. When you're only doing it for a short period of time, the side effects are a lot less, number one. And number two, Orgovix is a much better LHRH drug than if they inject you with a depot shot.
Okay.
The doctor I was referring to wasn't saying it doesn't wear off quickly. His problem with Orgovix was that it does wear off quickly compared to Lupron. And his argument to me was, well, you're going to miss out on that long decrescendo of Lupron that may or may not, in theory, have an extra cancer halting benefit.
I don't think so. I mean, first of all, people who take Lupron for a long period of time, an agonist for a long period of time, are in a completely different ballpark to you. You're in a ballpark where you want it to come in and you want it to go out, and if he's worried about the extra time, keep taking the pills.
Yeah.
If he's really worried about it, all right, take the pills for another month or 2 months if that's what he's worried about.
Exactly.
Keep taking the pills is what I'd say to him. I mean, I don't know where these guys come up with this rubbish. They come up with it because they can't get it for their patients and all their patients want it. So they come up with a reason why the Orgovix isn't so good.
Rick, I also heard they make a pretty penny on the shot.
Yeah, I think it's like.
Oh, they make a lot of money on the shot, and that's a whole nother. We're not going down that rabbit hole, John. Go ahead. Go back to you, Bill.
All right, Steve, you got anything else?
Yeah. Any thoughts on dealing with ED issues? Like Viagra and things like that, and when to start.
Well, I had a prostatectomy with nerve sparing surgery, and it was successful, but it took time to realize that it was successful. But my surgeon talked about, and you're talking about radiation. So, but my surgeon talked about it prior to surgery, and talked about the nerve sparing, and then said after surgery, there's different physical therapy things that you can do for erectile dysfunction. So, and so I was, once I was recovered from surgery, they had me on that protocol already. So.
I talked to the urologist here, and he said to consider it sooner rather than later, like before the treatment.
Consider what before the treatment?
Cialis or Viagra.
I didn't take any pills prior to surgery or anything. No, but I don't know what's the rate of incidence of erectile dysfunction with radiation treatment. Because I had already had the surgery, so I had it before I had to take the radiation treatment the year following that. So
I think it's 25%. It's the number I remember.
Oh well, wait till after surgery and see if you can still do it.
Well, I'd like to get on this thing beforehand, but yeah. So a couple other.
Can I come in for a minute?
Well, all the hands started popping up when you started talking about this, Steve. Hold on a minute. Go ahead, Govinda.
Yeah, I had advice from my doctor after my SPRT about 10 years back. What he told me was you can take a small dose of Cialis or Viagra every day, or you can take a full dose when you feel like doing something. So I told him, look, it's very difficult to take when I feel like take something and wait for 1 hour to do it. So I prefer to take every day a small dose, and which has been quite successful and useful for me.
How big of a dose did he say? Like 5 mils or something?
It is half a tablet of Viagra.
I couldn't
Small
get
dose.
it. 5?
Yeah, we're having a hard time hearing you, Govinda.
Yeah, because it's coming from India possibly. So it was something like, I think, 0.5 milligrams or something like that.
Okay.
I will check and put it on the chat box if it is possible.
Okay, great. Let's see what else. Any thoughts on dealing with insurance companies? I mean, I'm using Cigna now, and they were great to take everything up until I hit the deductible, and now I haven't heard back, and it's probably got about six or 7,000 outstanding. I'm not sure whether.
I personally don't have any advice on dealing with insurance companies. I have a military TRICARE system, and I've never had an issue with anything that I can remember, as far as coverage or things like that. So,
okay.
You said you have Cigna?
Cigna Global, which doesn't cover the U.S. actually, so I'll be self-paid for this thing, which I still haven't got a quote on. Actually, I'm still waiting on the number. I suspect it's going to be around 50 or 60,000, but I'm not quite sure.
Well, if you use the Cigna Global, they would treat you in Malaysia. Then is what you're saying. Then they would cover it. But since you want treatment from a United States-based, they're not going to cover that.
That's right. No MR Linac here, and even if they had it, I'm not sure I would want to use it because the volume is not very huge.
Yeah, I think you're our only international caller tonight. So.
Okay.
And Govinda's on there, but I don't. He's here half the year, so.
Okay. I think that's kind of it. I mean, I guess the only other thing is I'm still trying to get in touch with. Well, I'm kind of in the middle of onboarding with UCLA to trying to see Keyshawn, and I've sent some notes to Stuart along the way about that. I went through international patients. I had to explain what the medical records were about here in Malaysia, and then they eventually accepted it last Friday. So I'm still hoping to see them when I'm on my trip. But probably in the next day or two, I'll hear something. I'm kind of crossing my fingers. I get that because I'm pretty interested in Keyshawn for the treatments.
Stuart, he mentioned your name and you had your hand up, so.
Yeah. Hey, Steve, just thinking about, oops, thinking about your insurance question and not being covered in the U.S. Would Cigna cover Australia?
No, I've got the sort of local version, which is
Oh.
your home country, Canada, and Malaysia. So
Oh, I was just thinking because if Australia was covered, that could be another option for treatment. But if
well,
they're not covered, then
I did go through Canada with clots because apparently they do it, but their follow up has been pretty bad. So I'm actually I'd rather pay the money than put my hands in that, because I literally I had a consult with him. It was very random. I asked a bunch of confirming questions via email. They never responded. His admin didn't respond, so that left me a little left me wondering. Though
that can be frustrating.
Surveillance, but not for anything else.
the other, just quickly to go back to your other question about the ED, when you're at Stanford and if you get to UCLA, talk to both of them and ask specifically. They very well have specialists on staff, because like at MSK they do. And if you want, you can get some real straight talk from them in terms of what they can do and when, because they have the most experience. And that's again one of the benefits of going to a center of excellence.
Okay. Awesome.
Steve, could I chime in? I started Cialis 5 milligrams daily a week before my radiation. And I just continue it just to keep all the blood flow in the nerves, the blood vessels, because radiation ages everything down there. So you just want to exercise and keep everything. Cialis will keep the blood flowing down there. And so far, knock on wood, there's a 40% chance of ED. But remember, as we get older, you're going to get ED. Right. I mean, so
mine still works.
Yeah, no, mine works perfectly. But as you get older, 5 years down the road,
yeah, I get
it's
not quite as virile as it used to be, especially after that biopsy.
But 5 milligrams Cialis is what most guys do before the radiation and continue at least 2 years out.
How long after, or how long before did you start, did you say?
I started about a week before. Some guys start a month before. I've never taken ED medicines before. So just continue it, and 13, 14 months out. So just what the protocol for most guys doing radiation do.
Okay, great. Thank you. I think that wraps it up for me. Thanks, guys.
All right. All right, thank you. We had Tom from New Jersey. You said you wanted a little bit of time.
Good evening, everybody. So just sort of, I guess, more a couple questions and an update of where I'm at. Been listening to you guys for a few months. Diagnosed in August. It's unfavorable intermediate. I've got I got a recent PSA, which now has me at 8.5. The majority, actually, all of it is prostate confined. They did find a couple lymph nodes outside of the prostate that were questionable. Unfortunately, they're non-biopsyable, so they can't distinguish what they are or if they're cancerous or not. So that's kind of got me in a quandary. I was with the radiation oncologist, met with the medical oncologist Friday, had another blood test done. They're doing the BRCA test. Tomorrow I'm meeting again with the surgical oncologist, and still at this point I'm kind of leaning towards going for the surgery, because it is, for me, since they can't tell me what the lymph nodes are, we know it's in the prostate, so I'm thinking just take the prostate, just take the surgery route. And hopefully that nips it in the bud, because my reservation with the radiation is the fact that post radiation, you're not a favorable patient for surgery, is my understanding. Is that everyone's understanding, right? I mean, the radiation kind of wrecks
Like
you.
that's what we kind of covered before when Rick said that. Like when I was diagnosed, I heard the exact same thing, but it's not the actual prevailing school of thought anymore. There are doctors that will tell you it doesn't matter if you had radiation first, you can still get surgery afterwards. So.
Yeah, this is MSK I'm working with, and
did I miss something? How did they find the lymph nodes? What test did you have?
The MRI, the PET scan.
Oh, PSMA?
Yes.
Oh, okay. I must have missed you when you said that. I was listening.
No, I didn't say that today, but I don't know how deep your notes go, but it was on a previous meeting I was on.
Yeah. Okay.
Yeah. So they're not, obviously they're not committing. They're not saying do this, do that. But my concern is that if I do the radiation, that it's going to make the surgery harder, because it does destroy the tissues around there and all that. The radiation person was totally fine, extremely young, but I guess if you're working with modern technology, you want a modern doctor, you know. I don't know. I'm in a quandary. I mean, tomorrow I'm going to speak to the surgical oncologist, because I think I'm just going to get it taken out and hope that's it. You know, I'm going with my gut. My gut tells me that it's prostate confined. Just take the prostate out. You know, I don't think there's any great loss there. I think if I go with the radiation, could it get it all? I don't know.
Well, yeah. I mean, if they're fairly certain it's confined to the prostate, and there's probably a higher chance of getting it all, as you say. But they are removing an organ from your body. It's a major surgery, and there could be significant side effects, right? So
yes,
you have to prepare yourself for that also at the same time.
Well, I asked them both flat out, which one has the worst long-term effects, and it's radiation, from what they're telling me.
No.
Is that incorrect?
Who are you talking to there?
The surgeon.
A dye?
Oh, no, the surgeon is
a dye?
The surgeon is Gaffney, and the radiation oncologist is Yalamancelli.
Okay. I don't know Gaffney.
They both work under Michael Morris over there.
Yeah. Well, they don't work under Michael Morris, because Michael Morris is a medical oncologist, and so the surgeon works under Eastham, and the RO works under whoever is now heading up radiation. Who's heading up radiation oncology, Stuart, at MSKCC now? You know, Zalewski went off to NYU. This is not in accordance with general wisdom, Tom. It just are these doctors both at in the city, or are these doctors in one of the satellite facilities?
They're in the Basking Ridge facility in Jersey.
There's your problem right there. Get yourself out of that Basking Ridge facility. Don't get your surgery there. It's not the place to do. If you're going to go to MSKCC, you need to go to the city, and you need to do it with surgeons who are experienced, have been around there a long time, and the same thing with the radiation oncologists. I would not trust what these people are telling you. And we've seen this before, where the satellite facilities, whether it's Monmouth Hills, whether it's Baskin Ridge, you don't get good information. It's not Memorial Sloan Kettering. It might have that label on it, but it's not Memorial Sloan Kettering. Period, period, paragraph. You didn't come to us and ask us that, but now we're telling you, speak to Stuart.
Yeah.
Speak to some of the guys who are in there. It's not the place to do it. And they're giving you bum information that, yes, you can't have, you can't get radiation after surgery. Yeah, you can't, because that surgeon doesn't know how to do it because he hasn't been around long enough. If you ask Eastham or if you ask Laudon, they'll tell you, yeah, we can do it, because they're the guys who are at the top of their game there. And you know, in terms of the radiation, I'm not sure what it was they told you, but I'm concerned about the information. Stuart, you want to comment?
Well, yeah, you know, go to Manhattan, you're talking about the world-class doctors. They're all the best in their fields. Eastham, you know, is gold standard as far as surgery goes. Dr. Nagar is top 5 in the country in terms of doing MR Linac. You know, the bench is so deep there, you almost can't go wrong. So I know it's a little bit of a hassle to commute into New York, but it's worth it. You know, I'm in Connecticut. I went to Manhattan for my treatment. You deal with it.
I'm not worried about the hassle. Is it? I mean, are you allowed to switch? And can I switch inside the MSK?
Very difficult.
Yep.
Yeah.
We've done it. We've seen guys do it, but it is not easy, and you've really got to advocate for yourself. They really don't like to do it.
If there's a way to do it, it's because you're changing to get access to a treatment that they don't have in the other location.
Yeah. Yes. Great
So,
point.
like for instance, if you were to call and get an appointment with Nagar for the MR Linac, you probably don't have an issue. You know, same way if you wanted proton, you could get switched on that, because again, they don't do it in the other location. The straight surgeon could be the biggest challenge.
Yeah. Well, what is the MR Linac?
They do SBRT treatment in an MRI. The MRI is monitoring real time the process, taking pictures, you know, every millisecond. And if there's any movement, it stops the beam, so they can work with tighter margins and higher level of safety of not hitting the good tissue. MR Linac is, you know.
So that's part of radiation.
The radiation treatment, yeah, and it's usually higher dose and less treatments.
Tom, could I ask you, the PET scan showed pelvic node involvement? What's the percentage? Was it outside? I mean, what are we talking about here? Because I had a little uptake in my pelvic node, but Dr. Nagar ordered the DECIPHER test, and it wasn't much, and he thinks it was a false positive. So, DECIPHER score. Yeah, go ahead.
Yeah, the lymph nodes outside, they have no evidence on yet.
So where
everything's everything's concentrated on the prostate, on the right side.
So what does this have to do with lymph nodes outside or inside?
They're in the pelvic floor. They're they can't even they're non-biopsyable. He says he doesn't even think he can get them with surgery.
Well, I mean, that's really significant. I mean, are they saying that there are lymph nodes that have PSMA, that from the PSMA scan there are lymph nodes outside of the prostate?
Yes.
Yeah.
And he says that he still wants to do surgery?
He's not saying he wants to do surgery. He's telling me it's an option.
Well, it's, you know, it isn't, it's really not an option in the sense that the reason we do that PSMA scan is if we are certain that that there are lymph nodes outside of the prostate, we avoid surgery because especially if we can't get them. I mean, you know, the guy should be saying you're not a candidate for surgery. I'd tell him you want a second opinion from Dr. Eastham. And Dr. Laudon. I mean, you know, it doesn't make sense. Now, if he's saying something else, he's not sure if they're there, but if he's saying he doesn't even think he can get to them, so he's saying to you, you're going to have the surgery, but we're going to be leaving PSMA positive lymph nodes. There's something wrong there. This is not.
No, they haven't been. Yeah, they didn't do any. The lymph nodes didn't show up until the PET scan. The only thing.
Well, that's why we do the PET scan.
Exactly.
That's exactly why we do the PSMA.
And what is it should say it on the report what the percentage of uptake is. Like unlikely, likely.
It says unlikely. And because they tried to show them to me. It took the radiation oncology.
In front of you, Tom?
Yeah.
I think Rick wants, if you could read it for us.
Yeah, the PET scan says. So, they're called indeterminate small pelvic lymph nodes, possibly reactive, possibly metastatic. No suspicious osseous lesion.
Well, for sure, you want a second opinion on on those nodes, and you want a second opinion on whether it would be smart to get surgery in the face of having those nodes there. I can't tell you, I don't know enough, but you need you definitely need a second opinion. Go over to go get a second opinion from what's his name over across the street at Weill Cornell? Who? Stuart.
Jim Hugh.
Jim Hugh. Go get a second opinion from Jim Hugh on what's going on there, and don't make any decisions yet.
Rick, he's a surgeon. He wants to do surgery.
That's not true. Who said that? Was that you, John?
He did my biopsy, and he told me
I get it.
Stuart, can you put up his contact information?
I get it, but by the same token, I would say that some of these docs are fair, and I think, you know, Hugh's pretty fair. And he's not going to say we should do surgery if it's clearly outside the prostate. And I definitely go see Nagar and ask Nagar what he thinks. I think that's a terrific idea on Stuart's part.
I would see Nagar, from my experience. I kind of had the same thing.
I'm sorry, what was that one? I missed that.
Yeah, Nagar, I had kind of the same situation you did, just a little uptake. So Nagar reviewed it with his radiologist and determined that it was nothing to be concerned about.
Well, yeah, because with radiation, they can get at it. So he can treat it with the radiation. But what concerns me is, how do you treat nodes that you know are outside the prostate, which also means that if we know they're outside the prostate, they could have spread, and so we need to do more aggressive treatment. What are they classifying you as? What's your stage?
I'm intermediate.
What is the current Gleason score of your? And are you a T3? Do they have you as a T3? Because T3 isn't intermediate anymore.
Yeah, I know it's Pyrad 4, Gleason score. Where do I find the Gleason score?
Okay, has the Gleason score, has anything been changed as a result of this PSMA? You need to know what they're staging you now as a result of this PSMA, Tom.
Okay.
Ask them what stage you're at, because if we see lymph nodes outside of the prostate,
Yeah.
then we should be staging you as a T3, which means you're high risk. And so that changes everything.
Yeah. So my Gleasons are 4-3, 4-3, 3-4, 4-3.
Okay. And what are they staging you? What are they staging you now after the PSMA scan?
Yeah, nobody gave me a stage.
Well, you need to ask them, what stage am I? You were before you were something like a T2A or a T2B.
Yeah, well, that would be on this report. I don't see it though.
Well, it might not be on that report. It should be, but it might not be. But now you want to know, what stage are you? Because I get the feeling that you've moved from intermediate to high risk, and you should be having different conversations if we know that there are confirmed nodes in the bed of the prostate.
Yeah.
I'm a little concerned on time. I know that Albert's got some important stuff that I think he wants to talk about, and it's already 8 o'clock. But I think if you are if they've staged you to a T3, which I suspect they may have done, come into the high risk on Tuesday and we'll talk some more tomorrow. Come into the high risk tomorrow and we'll talk some more with you.
Okay.
You need to get hold of them right away and find out, what stage am I?
Yeah. Well, I'm meeting him tomorrow. So.
Okay. If you've got lymph nodes outside of the prostate that he feels he cannot get at, and they are prostate cancer, and he tells you that you're still a T2, he's blowing smoke up your ass.
Okay. Well, we'll find out tomorrow. No decisions yet.
You've got to be your own best advocate, Tom.
No, I know. That's half the reason that I keep coming back here, because I love the audience and I love the input.
It just doesn't make sense that it doesn't make sense if we've got lymph nodes outside of the prostate. That is exactly why, that was why PSMA scans were approved for staging. That's how they got their approval for staging.
Yeah.
Pre-recurrence, for exactly this reason. And if you are, then you would not be a good candidate for surgery under any circumstances.
Okay, very good. I appreciate it, as always. Thank you.
All right. I'm glad we could help, Tom. I asked earlier about those lymph nodes, and I just, for some reason, that was just niggling at the back of my brain. The fact that it showed up on the PSMA and it was outside of your prostate. So, all right. So Albert, you were up next.
Yeah, I think I can try and be brief. I want to say to Tom, though, I'm glad that you were able to get a lot of good input tonight. And yeah, I think you're in a tricky situation, and I'm happy that you're coming and hearing what people have to say. So, and I feel for you. Anyway, I finally got my paperwork in to Epstein for my second opinion on my biopsy. which showed me at 4+3. I scheduled a PSMA at Mayo for tomorrow, but I'm thinking maybe I won't do it. And my main question for tonight is, I discovered that there is a newer PSMA machine that is called Quadra. It's by Siemens. And the Mayo in Phoenix has the older GE machine that is not as precise and maybe exposes you to more radiation. So my first question is that even an issue worth considering? Well, actually, the very, very first question is, I believe that, I think it was Rick or someone indicated to me last time I brought this whole thing up, was you don't really need to do anything until you get your, don't do your PSMA until you get your second opinion from Epstein. So I'm thinking I'm going to cancel my PSMA for tomorrow. I can get it again in Phoenix, apparently in about 3 weeks from now, if I want to. And if I want to go for one of these Quadra PSMA with this new machine, they have one in Rochester and they have one at UC San Francisco, apparently. So I could travel and do that if it's worth it. But I think I was told in the group here, well, it's all cart before the horse until you get Epstein's second opinion. So is that a good idea to just hold off on the PSMA until I see what Epstein says?
Where exactly are you with Epstein? Sorry, something. I had to shut off for a second.
That's okay. I have sent in the paperwork. I called him today. He wasn't in office. I had to submit it to fax it to Mayo's pathology department per the instructions of Epstein's assistant as to how to fill out the 2 forms. I followed them to the T, but I'm not sure that Mayo will be happy with it. So, you know, okay. It seems like
so let me cut to the quick here.
Good.
Why don't you let Epstein pull your slides rather than you trying to push the slides to Epstein?
So I would call Epstein and ask him to call
Mayo.
Mayo.
Call Epstein and say you want him to pull the slides.
Okay.
That's the paperwork, and fill out that paperwork. Let him pull the slides let him request your slides.
I think I did that. I think I remember that I was instructed here that that was the best way to do it. And he said, no, I'll send you the forms. You fill them out. You send them to pathology at Mayo and they will respond. So I can go back to him and say, okay, I did what you told me, but now I want you to also do something else. I want you to somehow pull the slides, right?
Well, you can say to him, I've done it.
Yeah.
But would you mind following up to
Awesome.
make sure they send them to me?
Yeah, I'll do that.
To you because you're worried that they're going to be reluctant to send the slides.
Right. Okay.
Right. That's how I would handle that one.
And now, okay, go ahead.
Would I? The question at hand is, would you go ahead with the PSMA until before you get his second opinion? Here's our concern, all right? If Epstein says you're a 3+4, depending on the location of where the lesions are, you don't need a PSMA scan. And one of the problems, and this is probably our own pet peeve here, is people get tests when they don't need them. The reason why Dan What's-His-Face is ordering the PSMA test is because you're a 4+3. And he's pretty much required now, if you're a 4+3, to make sure that the disease is not outside the prostate. So
Yeah.
Go ahead.
Well, if the pathologist at Mayo Phoenix comes up with 4+3 and Epstein comes up with 3+4, is it safe to assume that Epstein is right and not do
Yes.
the PSMA?
Yes.
Yes. Okay, good. Well,
It
then
is safe to assume, and probably even the pathologist at Mayo at Mayo Phoenix would defer to Dr. Epstein.
Oh, okay. Perfect. Because I didn't want to experience the test myself. I was like, why put myself through the radiation and all of that for if I don't need it? So I'm going to go ahead. I'm going to cancel for tomorrow. I'm going to I'm going to talk to Epstein about reaching out because I'm concerned about reluctance from Mayo on releasing the slides. And then once I get my result, I'll know what to do.
That's the way I would go. I'm losing his last name. What the heck's his last name? Your surgeon, Dan?
My surgeon?
Yes.
Oh, it's Frendel.
Frendel. That's it. I couldn't remember his
Dr.
last
Frendel.
name.
Right.
I knew it began with an F.
Yeah. Yeah, I met with him today, and he talked about treatment. He does the cyber knife and also the HIFU treatment, and he talked about pros and cons of that. But
he doesn't do cyber knife. He's a surgeon. Well, they may do it, but cyber knife is a radiation treatment.
Right. Well, and HIFU is too, isn't it?
No, HIFU is a focal treatment that's usually done between a mix of a urologist and a radiation oncologist.
Well, he definitely told me he does cyber knife. He said, I can either do, if you want to work with me for treatment, I'll do cyber knife or HIFU.
Well, I don't know, unless he's talking about some type of laser beam. I don't know. Stuart?
He said it was an ablation.
Oh.
Sorry, Albert, what was the last thing you just said?
He said it was ablation. He called both processes an ablation process.
Okay, my guess is it possible that he said nano knife and not cyber knife?
That's what he said. I'm sorry, I got my knives mixed up.
Okay, so here's the concern I have. He's talking to you like he's willing to do a focal ablation. And if in fact you're a 4+3, you're not a candidate for a focal ablation.
Okay.
And I would be pushing back on Dr. Frendel and saying, Dr. Frendel, I'm a 4+3. You know, from everything I know and from everything I hear, I'm not a good candidate for a focal ablation.
I think he's saying because it's all on the left side.
Yeah, but he doesn't know that because there could be micrometastasis.
Right.
That's spread it over to the right and he can't see it. And that's why we tend to avoid focal ablations with men who are 4+3, only 3+4s.
Okay,
These doctors, and I like Frendel, but I would argue with him all night. You're not a candidate for a focal ablation with a 4+3. How does he know where the heck the 4's gotten to? And then what's going to happen is 2 years later it'll come back, and then we'll be going through this again.
Well, he was saying it's an 80% success rate. A year later, you are MRI and biopsy again, and you see where you're at.
Yeah, it's an 80% success rate if you're a 3+3 or a 3+4.
Okay.
Ask him what the success rate is if you're a 4+3.
Okay, good.
You know, I mean, they give you this line of bullshit. It makes me, it's not right.
Well, that's good to hear. The only other concern I have about not proceeding more rapidly is there are cribriform structures in the 4+3, although Epstein said, well, there's better and worse cribriform, and it may not be that big of a deal. So short of that being a concern, I'm happy with just getting Epstein's second opinion. And then
I would do that first, Albert, number
Yeah,
one. And number two, if it were me, I would never consider any type of focal ablation, even if it is all on one side, if I was a 4+3 or higher.
okay, that's great to know. The other thing, I don't know if that we have time tonight, but you know, at some point I want to address I don't even know if I need to do the PSMA, but is the Quadra better, or can you just go with whatever machine like the old GE machine?
I don't know enough about the Quadra. I think it has something to do with being. I don't know. I don't know. I don't know. Where are you? Who's telling you about the Quadra?
I just discovered it online researching. I'm like, are there better and worse PSMA machines? And yes, there are. And in fact,
I don't know enough.
What's that?
I don't know enough. I can't comment.
That's good. The other thing is my DECIPHER went to 0.52 from 0.27. 0.27 was my first biopsy in 23, and 0.52 was this from the one in December of 25. So I don't think that's enough of a concern to not just wait for Epstein. I'm going to do that. And the thing, you know, people brought up Schultz as sort of a, I know Frindle is a urologist, and I don't really have a doctor that's my oncologist and that sort of thing. So at some point I want to address that, but maybe I should leave it for tonight.
You don't need an oncologist at this point in time.
Right. Yeah.
Okay, you don't need a medical oncologist right now at this point in time.
Okay.
With a diagnosis of either 4+3 or 3+4, you don't need a medical oncologist. If you knew that the cancer was outside the gland, like in Tom's situation, maybe we need to get a medical oncologist involved to advise him, possibly.
Okay.
Possibly.
Okay.
But we don't know. We've got to get that, and that only to advise him on what type of treatment to move forward with. But we don't know enough. Tom doesn't. In your case, you don't need one. I mean, people hear of this, that, and the other, and then they want everything, and they want to.
Well, if you're at 4.3, don't you need treatment?
Yes, but you either need radiation or you need surgery.
But so you don't need a a radiation oncologist at that point?
You need a radiation oncologist. You don't need a medical oncologist.
Oh, okay, great. All these terms I sort of mix up. Okay. Well, then I don't really think I need to do anything else tonight, do I? Until I'll just find out what Epstein says. And
just wait for that second opinion, Albert.
Yeah.
And
Okay.
then come back to the next group and we can discuss it again.
Yeah. Okay. Thank you, guys.
All right. We are over time, but we're always happy to talk to you guys and try to get everybody in. So anybody got any last anybody got any save rounds, as Steve would say, from the Army?
Is Bill from is Bill, I think Bill's gone. Oh, no, he's here. Bill from VA. You said you had something quick.
Yeah, I'll go quick if I can. My PSA has been rising since about this summer. I spent a year at about 5.2. Now it's up to 6.3. So what we decided to do was get another PSA. Did that at the beginning of January. It's still 6.3. And so now I'm getting set up for another biopsy to see where we should go. The concern is that the lesion is butting up against the margin. That's the update.
How long was it since your last biopsy?
It was May of 24.
And what's your Gleason?
3+4.
And your question?
I don't have a question. It was just an update. Okay. I'm here listening to decisions being made about treatments for the most part.
Okay. Anybody else before we close it out tonight? And Bill, I apologize. I did have you down for time, but you were on the second page and I had scrolled up to the other page and I missed you at the end there. So my apologies.
I don't want to run this any longer, but I just had a question about Tulsa Pro. When's the next time the group meets?
We meet in 2 weeks.
Maybe I can just wait till then and queue it up for
same bat time, same bat channel.
All right. So Tulsa Pro was a question for next time.
Okay.
Thanks.
So go into our webinars again and take a look in Tulsa Pro for Tulsa Pro and listen to the webinar that Klotz did for us.
Okay, great. I'll do that.
But again, Tulsa Pro is a focal treatment. We here at AnCan, we tend to think there is no real place for focal treatments. For some people with 3+4, which that's what you are, correct? 3+4?
Yep.
For some people with 3+4, it may be suitable.
Okay, I'll look at the webinar. I won't hold anybody up tonight.
If you're 3+3, you don't need it. If you're 3+4, you may need it. But the biggest problem is there's a very high recurrence rate. I don't know where Dan Frendel's getting his 80% from. I mean, I don't know. It's just crazy because no focal treatment, if you look at all the research and you read a lot that's been written and get into looking at focal treatment, the best it has is 50% success rate. And that's not very good. So I wouldn't even, if it were me, I wouldn't even be thinking about about Tulsa Pro.
Okay, thanks for the summary. That's quick.
All right. All right, gentlemen, thank you for joining us and hope to see you guys again.
Thanks, everybody.
That concludes our meeting. I am now going to stop the recording.
Thanks, guys. Bye, everybody. Next time.